Assalamu alaikum. Hope you are all well. Bismillah ar-Rahman ar-Rahim. Let's start today's lecture. Today we will talk about hormonal contraceptives. The learning objectives are, after completion of the topic, you will be able to define hormonal contraceptives and list their types. Number 2, describe types and subtypes of oral contraceptives with examples. Number 3, describe mode of action of combination oral contraceptives and progestin only contraceptive. This is very important. You always get this question. Then describe following aspects of combination oral contraceptive preparations: pharmacological effects, their therapeutic uses, and their beneficial effects other than contraception, adverse effects, drug interactions, and contraindications. Then describe progestin only contraceptives briefly. Now, what are these hormonal contraceptives? These are the hormonal preparations which are used to avoid conception and pregnancy. The types are oral contraceptives, injectable, then implantable contraceptives, transdermal patch, intrauterine devices, and vaginal ring. The oral contraceptives are used worldwide and they are reliable, affordable method of contraception. Two types: combination of estrogen and progestin or combination oral contraceptives, and number 2, progestin only contraceptive, in which there is continuous administration of progestin only, no estrogens are given. Let's see what these combination oral contraceptives are. They contains both estrogen and progestins. The most commonly used estrogen is ethinyl estradiol. Apart from these, estradiol, valerate, and mestranol are also used. Then commonly used progestins are norethindrone, norgestrel, L-norgestrel. Others are dinogestrol, drospirenone, drospiron, etonogestrel, then norgestomine. Norgestomine is recent, it is less androgenic. There are certain adverse effects which are produced by androgenic progestins. So in those cases, we can change with the non-androgenic. Then subtypes of combination oral contraceptives, they may be monophasic pills. They are generally packed in small packets of 28 tablets. 21 tablets contain hormones and 7 are placebo. So all the 21 tablets, they have the same amount of ethinyl estradiol, that is 0.2 milligram, and L-norgestrel 0.1 milligram in AVM. So this is monophasic combination contraceptive. Then we may have biphasic in this, like for example, Nikon. From day 1 to 10, these 10 tablets, they contain estrogen, ethinyl estradiol, 0.035 milligram, and norethindrone, 0.5 milligram. But in the next 11 tablets, estrogen amount is same, but amount of progestin has been doubled. So this is a biphasic pill. Then we can have triphasic pills from day 1 to 6. Ethinyl estradiol 0.03 milligram. From 7 to 11, it is 0.04 milligram, and L-norgestrel was from 1 to 6 days, it was 0.05, and from 7 to 11, it has been increased to 0.075. Estradiol first increased from 7 to 11 days, now from 12 to 21 days, again decreased to 0.03 milligram, and L-norgestrel has been increased to 0.125 milligram. So these triphasic tablets like Trifizal, Trivura, they try to mimic the natural female cycle. Then tetraphysic pills, Natassia, in these 4 different combination of the hormones from day 1 to 2, estradiol, valerate 3 milligram and no progesterone from day 2 to 6, estradiol 2 milligram and denogest 2 milligram, then from 7 to 25 days, estrogen is 2 milligram and denogest is 3 milligram. Day 26 and 27, estradiol, valerate decreased to 1 milligram and there is no progesterone. So we can have 4 types of these combination oral contraceptives. Now regarding few important points regarding their pharmacokinetics. They are well absorbed from the GIT and pharmacokinetics of one hormone does not interfere with the pharmacokinetics of the other hormone. They are metabolized in the liver by cytochrome P450 enzymes. Enzyme inducers can affect it. They undergo enterohepatic recirculation and broad spectrum antibiotics can affect. We'll discuss this with drug interactions. Now coming to their mode of action. Let's revise the normal effect of trophic hormones on these ovaries. So hypothalamus releases gonadotropin releasing hormone which acts on anterior pituitary and follicular stimulating hormone and luteinizing hormones are produced. In the beginning of the cycle, under the effect of follicular stimulating hormone, 5 to 6 follicles start developing, but then around 6th day, one of them become a dominant follicle and it grows at a rapid speed, and then about the mid-cycle, it starts secreting estrogen. Now these estrogens, they inhibit follicular stimulating hormone and other follicles, they regress. Now the granulosa cell in this follicle starts secreting progesterone. Due to these changes, there is a surge of luteinizing hormone in the mid-cycle, which induces ovulation. So here ovulation has occurred. Now, when the level of progesterone and estrogen increase by negative feedback mechanism, they inhibit anterior pituitary as well as hypothalamus. So these combination oral contraceptives, their main mode of action is inhibition of the ovulation through selective inhibition of pituitary function via negative feedback. So ovulation is inhibited and conception cannot take place. They are 99.9% efficacious. There are a few other effects which may contribute because this effect on cervical mucosa, it becomes thickened and difficult for the transport of sperm. There is decreased motility and secretion of fallopian tubules. So the passage of the released ovum from through the tubules into the uterus, that is delayed. Then there are alterations in uterine endometrium. There is increased glandular secretion in the luteal phase. So, and that is hostile for implantation of ovum. So there is decreased likelihood of transport of sperms, conception and implantation of ovum. These factors mainly play their role in cases of progestin only contraceptives because they do not always inhibit ovulation. But these combination contraceptives, their main mode is selective inhibition of the pituitary anterior pituitary function via negative feedback mechanism and inhibition of ovulation. Again, this is your UQ, very important. Then regarding their pharmacological effects, they also produce effects on ovarian function is depressed. We don't see big follicles or stromal edema. The maturation index of the vaginal smears is low due to progestins. Then after discontinuation, 95% of the females, they ovulate in the first cycles, a few ovulate within a few cycles, about 3 cycles, but some of them, they become amenorrheic up to several years. They also have galacturia. So we must do their prolactin levels because many of them, they have hyperprolactinemia. Prolactinomas are there and they are producing this hyperprolactinemia, and that is why they are amenorrheic. Otherwise, 95% will ovulate in the first cycle and the rest in a few cycles. On uterus, there is cervical hypertrophy and polyformation. Mucus is thickened. Progestins increase glandular secretion throughout the luteal phase, but 19 norprogestin and smaller amount of estrogen, those combination pills, they produce glandular atrophy and less bleeding. Then effects on the breast. On long-term use, there is stimulation and enlargement of the breast, and there is suppression of lactation but breastfeeding is not affected in small doses, only large doses can affect breastfeeding, and the secretion into the breast milk is also insignificant. So mothers can breastfeed their babies with these contraceptives. Regarding effects on central nervous system, they have not been really studied in humans, but in animals, this has been seen that estrogens increase and progestin decrease the excitability. Then we all know that progestin increase body temperature. This is again the central thermogenic effect. And this has been seen that in humans, there are mild changes in mood, affect, and behavior. That is why the estrogens have been used usefully in premenstrual tension syndrome and postpartum depression. Regarding their adverse effects, chronic use can produce severe depression in 6% of the patient or the females who are taking these tablets, and then they should be discontinued. Effects on the endocrine system, inhibition of pituitary gonadotropin secretion has already been discussed, and renin-angiotensin aldosterone system is stimulated. There is increased renin, increased formation of angiotensin 2, increased secretion of aldosterone, which will lead to increased blood pressure and retention of sodium and water. Thyroid binding globulin is increased, so level of total T4 is increased, but free T4 level is normal. And these changes are like in pregnancy. Then corticosteroid binding globulin is also increased. There are few changes in the adrenal medulla also, and the adrenal cortex also. And urinary excretion of free cortisol is increased. There is increased level of sex hormone binding globulin, so free level of androgens is low. Then large doses can decrease androgens by gonadotropin suppression. Effects on blood are important. There are changes in clotting factors like pregnancy. There is increase in factors 7, 8, 9, and 10, and there is decrease in antithrombin 3. Remember, your antithrombin 3 is a natural anticoagulant, and these changes, they prone to tendency for thromboembolism. Increased dose of warfarin is required to prolong the prothrombin time. Then this increased serum iron and total iron binding capacity, and folic acid deficiency anemia may occur. Then effects on the liver, these alpha-2 globulin synthesis and fibrinogen synthesis is increased. Hepatoglobulin synthesis is decreased. There is decreased flow of bile, and the change in the constituents of bile acid. Cholic acid is increased and chino-D-cholic acid is decreased. And due to this, there is increased tendency to polylithiasis. And with cholestatic jaundice may occur with progestin. So these are adverse effects. Effects on lipid metabolism. Estrogens produce dose-dependent increase in triglycerides and other phospholipids and decrease in low-density lipoprotein and increase in high-density lipoprotein. And progestin could antagonize these effects, which means there will be increased LDL and decreased HDL, which are not really favorable. Effect on carbohydrate metabolism is similar to pregnancy. There is decreased rate of absorption of the gastrointestinal tract. Progesterone increases basal insulin and after level of insulin after carbohydrate ingestion. Norgestrel has been seen to decrease in decreasing carbohydrate tolerance over years. So this is not good. This decreasing is an adverse effect. Decreased carbohydrate tolerance, hyperglycemia may occur, and this can even increase atherosclerosis. Effects on cardiovascular system, there is increased heart rate, increased cardiac output, and increased systolic and diastolic blood pressure. This rise in blood pressure may be significant, so we must monitor blood pressure in all cases. Then they have some effects on the skin. There is increased pigmentation of the skin, which is known as plasma, and it is marked in dark complexion and exposure to ultraviolet rays. Sequential pills or estrogens decrease sebum and acne, and androgenic progestin increase sebum and acne. So according to the problem the patient has, we can change the preparation. Now clinical uses, so they are oral contraceptives, so the main use is conception. They are very effective. Failure rate is only 0.5 to 1 per 100 women per year if the complete adherence is followed. But generally we see that it is 5 to 12 per 100 women year at risk. Why this failure occur? The failure may occur if due to certain drug interactions, like in these enzyme inducers like rifampin or phenytoin is taken, or broad spectrum antibiotics are taken, which will disrupt their enterohepatic recycling and their decreased bioavailability. So in both these conditions, there may be failure of contraception. Otherwise, well adherence, regular intake, so the failure rate is very low. Apart from contraception, they produce some other beneficial effects, which include there is decreased risk of ovarian cyst, decreased risk of ovarian endometrial carcinoma, and benign breast disease. Then ectopic pregnancy, iron deficiency anemia, rheumatoid arthritis, their incidence is decreased. Then there is amelioration of premenstrual symptoms, dysmenorrhea, endometriosis, acne, and hirsutism. In drug interactions, which may lead to failure, broad-spectrum antimicrobials, because they kill normal flora which are required for the enterohepatic recycling. So if that is affected, so decreased bioavailability and decreased efficacy and therapeutic failure. Then enzyme inducer, rifampin and phenytoin, they will accelerate their clearance, hence the plasma level is decreased, leading to therapeutic failure. Now, adverse effects of combination contraceptive preparations. These adverse effects are of significant importance. There's because we are giving these drugs to young, healthy females, and we are giving them for months. But still, the incidence of serious adverse effects is far less than risk which is related to pregnancy. Adverse effects, they are related to dose and type of the hormone. Change of the formulation may alleviate many of these adverse effects. We should try to select a product containing the smallest effective amounts of the hormone so that there should be minimum adverse effects. These adverse effects may be mild, moderate, or severe. Mild adverse effects, they are frequent but transient. Nausea, mastalgia, breakthrough bleeding, and edema. We should shift to less estrogen or with more androgenic progesterone, then these adverse effect may be decreased. Then there are changes in serum proteins which are related to estrogen content, increase TBG, increase CBG, increase fibrinogen, which increase the ESR. Now, raised level of these globulins can interfere with the hormonal estimations. Mild headache, which may be transient, is no need to worry, but there may be worsening or onset of the migraine, then we must discontinue the drug. Then there may be failure of withdrawal bleeding, either change the preparation or change the method. In moderate adverse effects, some of them may require discontinuation. Breakthrough bleeding occurs in 25% of the patient. If we give biphasic or triphasic these contraceptives, then this can be decreased. Then there are changes in serum lipids, like high doses of estrogen, they increase triglycerides, increase high density lipoprotein, and decrease low density lipoproteins. Progesterones produce reverse effects. Combination pills with small amount of estrogen and progesterones, they can decrease HDL and triglycerides. Then hypertension. New cases and worsening of hypertension may occur in 5 to 10% of the females. After discontinuation, blood pressure normalizes in 3 to 6 months. Then weight gain is more with androgenic preparations. So either we should change the preparation or we should advise the diet. Then increased skin pigmentation is more commonly occurs in dark skin complexion females, and if they are exposed to ultraviolet rays, and the incidence is related to the period of intake. Like after 1 year, only 5% will have this increased pigmentation, but after 8 years, about 40% will have this. After discontinuation, then this pigmentation very slowly fades away. Then acne occurs with androgenic progestins, and estrogenic will have the better effect. So we can change the preparation accordingly. Then worsening of migraine or onset of migraine, we must discontinue because this may start a cerebrovascular accident. Then they have urethral dilation and frequent bacteriuria, like pregnancy. Then vaginal infections may occur, and they are frequent and they are difficult to treat. Then amenorrhea. On discontinuation, 95% of the females they ovulate in first cycle, the rest in next 2 or 3 cycles, and a few may not ovulate for several years, and they have galactorrhea. We must measure their prolactin level because many of them have these prolactinomas. Severe adverse effects. They require cessation of therapy. Vascular adverse effects include venous thromboembolic disease, myocardial infarction, then cerebrovascular disease. Increased risk of various cardiovascular disorders at all ages, but more above 35, more in smokers than non-smokers, and if there are coagulopathies, that predisposes to severe adverse effects. Now, venous thromboembolic disease, this includes superficial vein thrombosis or deep vein thrombosis and pulmonary embolism. Now, there is 3 times greater risk in females as compared who are taking these combination contraceptives as compared to non-users. So, because in non-users this is 1 in 1,000, so in users it becomes 3 in 1,000. And the antithrombin 3, as we discussed earlier in pharmacological effects, it decreases, and it decreases during the first month, and it's stayed at this low level throughout the period of intake, and after stopping within a month it returns back. And risk is related to estrogen content. It's not related to age, parity, mild obesity, or mild smoking. There are certain conditions which predispose these females to these thromboembolic phenomena. Stasis, if they decrease flow of blood in the veins, if they increase coagulability due to increased factor 7, 8, 9, 10, and decrease antithrombin 3, and platelet function is changed, and there is increased fibrinogen. So all these factors will predispose these ladies to these thromboembolic phenomena. And genetic factors, because the genes which are involved in the synthesis of protein C, S, hepatic factor 2, and others. Then if we have a family history or history of prior episodes, this can help us that they are predisposed, and then we should take care. Then myocardial infarction. There is increased risk of myocardial infarction in users of combination contraceptives, and risk is more in those ladies who are having predisposing factors like increased platelet aggregation, decreased antithrombin 3, increased fibrinogen, and luckily risk is not increased in past users, and this risk is attributed to acceleration of atherogenesis, which is due to decreased glucose tolerance, decreased HDL and increased LDL, and decreased antithrombin 3 and increased platelet aggregation. And there is facilitation of coronary spasm also, which contributes to this myocardial infarction. In cerebrovascular disease, there is increased risk of stroke, which may be hemorrhagic stroke or which may be thromboembolic stroke. 37 cases per 100,000 users per year. Risk increases in current and not in past users, and risk is more in females over 35 years and those who are smokers. Then serious adverse effects related to gastrointestinal disorders, cholestatic jaundice, which is related to progestin content, and if there is a past history of jaundice in pregnancy, and if there is genetic predisposition, then it is common in first 3 cycles. And after discontinuation, cholestatic jaundice disappears in 1 to 8 weeks. There is increased incidence of cholangitis, cholecystitis, and polylithiasis. Then there is increased incidence of ischemic bowel disease, which is secondary to the thrombosis in the celiac arteries or veins. Then there is increased incidence of hepatic adenomas. And regarding cancer, there is decreased risk of ovarian and endometrial cancer. There is a small increase in risk of breast cancer in young females, but lifetime risk is not increased. Then there is increased risk of cervical cancer, but it is controversial because these females, they have papilloma viral infection, which is already a predisposing factor for cervical cancer. So it may not be due to these combination pills, rather due to that papilloma infection. Then 6% of the females taking these combination contraceptives may develop severe depression, and then we must discontinue. Then other adverse effects are alopecia, that is loss of hair, erythema multiforme or erythema nodosum, and other skin disorders. Now, what are the contraindications to use of combination pills? Some are absolute contraindications and some are relative. So absolute contraindications include thrombophlebitis, thromboembolism, cardiovascular disorders, or past history of these disorders, or cerebrovascular disorders, or their past history. Then recent or past history of vaginal bleeding, suspected tumors of breast, or other estrogen-dependent neoplasm. So these are absolute contraindications. We must not use the combination contraceptives. Then some contraindications, they are relative, which means that we should avoid or use with care in females with liver disease, with asthma, diabetes, hypertension, chronic heart failure, eczema, migraine, optic neuritis, retrobulbar neuritis, convulsive disorders, uterine fibroids, or adolescents prior to epiphyseal closure. Then we must consider drug interactions with enzyme inducers or broad-spectrum antibiotics. So apart from oral combination contraceptives, combination of ethinyl estradiol and norelgestromin is available in the form of transdermal patch. Each patch is applied each week for 3 weeks and 4th week is patch free. Total estrogen exposure is 60% greater than oral contraceptives, so the chances of thromboembolism are more. Then vaginal ring, which contains ethinyl estradiol and etonogestrel, is also available. So that is about these combination oral contraceptives. Then oral contraceptives can be progestin only. In this, there is continuous administration of progestin for 21 days. No estrogens are added. This contraception is useful in patients who have prior thromboembolism, or they have hepatic disease, or they are hypertensive, or they have psychosis or mental retardation. Then we should prefer this progestin only contraception. Their mode of action, these progestin only contraceptives do not always inhibit ovulation as contrast to combination contraceptives. So the other effects of progestin, like increased thickness of cervical mucus, motility, and secretion of the fallopian tube, which is decreased, and there are alteration in endometrium. So this will lead to decrease or inhibition of the transport of the sperm, then inhibition in the transport of the ovum into the uterine cavity and conception, and embedding of the ovum will not occur. So these factors play main role in case of progestin-only contraceptives. Progestins are also available in the form of injectable contraception, depo-medoxyprogesterone acetate, 150 milligram by intramuscular injection for at least 14 weeks. But after stopping, it may take 18 weeks for that ovulation may be inhibited. It reduces blood loss and it also decreases endometrial cancer. Now this injection, it suppresses endogenous estrogen secretion, so there is decrease in bone density, which can lead to osteoporosis or even fractures. So generally they should not be used for more than 2 years. Moreover, suppression of estrogen secretions decreases HDL, increases LDL, and which predisposes to risk of atherosclerosis. Then progesterone intrauterine devices are available which release levonorgestrel. It is effective for 3 to 5 years depending upon the type of the system. Then implantable progestin in this subdermal etonogestrel capsules or small tubes. They are placed near the elbow under the skin, and naturally the surgery is required for that. They are effective for 3 years, and the hormone released is 1/5 to 1/3 of the as compared to the tablets, oral tablets. Due to this, there is little effect on lipoprotein and carbohydrate metabolism and on blood pressure. Disadvantage is that they have to be put surgically and removed surgically. The caution is to check for papilledema because previously norgestrel were being implanted and a few patients has raised intracranial pressure. That is why we must check for papilledema. Then these progestin-only contraceptives can produce episodes of irregular, unpredictable spotting, which is the most common adverse effect. They can produce headache or dizziness, depression, weight gain, reversible reduction in bone density, decreased HDL, increased LDL, which leads to risk of atherosclerosis and reversible reduction of glucose tolerance. And postcoital or emergency contraception, morning after contraception, taken within 72 hours of an unprotected intercourse, they are effective 99%. High doses of progestin or estrogens or combination of both or mifepristone may be used, but they must be combined with antiemetics because high doses can produce severe vomiting. Then chemical contraception in men, an effective oral contraception still not available despite many trials. Okay, if any questions or any queries can be asked in the Google Classroom, and inshallah we'll have interactive sessions for these lectures after Eid. Thank you.